I think the thought with stim is it's just to warm the quad up, get people feeling their muscle. But if you look at the research, we're supposed to be doing it at 50% of somebody's max volitional isometric contraction. And if you've ever hooked yourself up to an isometric machine and tried to turn stim up to 50%, you have to be a complete masochist to get there. So
Welcome back to the True Sports Physical Therapy Podcast, and thank you so much for listening to this episode with Dr. Rob Rowland. This conversation taught me a tremendous amount about how to be a better sports physical therapist, and that's what we're about. This conversation will make you a better sports PT. Dr. Rob graduated from the University of Delaware in 2011 with his doctorate in physical therapy. That is the #1 ranked orthopedic school in the world. He then worked in private practice for 4 years before he got a job with Army Special Operations, where he was in charge of all of their rehab processes. He then moved on to the University of Maryland, where he currently works and teaches in their School of Medicine, PT school. He teaches musculoskeletal as well as imaging. So outstanding blend of everything that he did in special ops. He also works with all of the Division I athletes at the University of Maryland, go Terps, as well as with UMBC retrievers. Tremendous amount of wisdom dropped in this conversation, from how to cue elite level athletes, how to use force plates, how to diagnose and then rehab a smattering of knee injuries. Really learned a ton. I know you guys will too. Without further ado, here's my conversation with Dr. Rob Rowland. Welcome to the True Sports Physical Therapy Podcast. You got to see a little bit about, a little bit behind the scenes as we got all this crap set up. So thanks for your patience.
Yeah, what is this place? I didn't know where I was coming.
So this is the home of the world's best financial advisor, Clipper City Capital. I have like a mini cubicle in the far corner. He lets me use this when I have legends come in.
Wow.
Yeah, so shout out to Clipper City Capital. Shout out to Rob Rowland, because I've been working on this for a decade trying to get your ass in here.
Had no idea.
It would have helped if I would have asked. Okay, Rob, tell me what your official position is at University of Maryland.
Official position is I'm core faculty at University of Maryland School of Medicine. So I'm core faculty for the DPT program.
Core faculty means?
It means, I don't know. It's a good question. I ask that sometimes myself. It means I'm a voting member of anything that goes on with the DPT program. So 30% of my time is committed to teaching. 70 to 75% is clinical. So I'm the team PT on campus at University of Maryland with the Terps, and then on campus with the UMBC retrievers.
Okay, so you're in classroom 30% of the time.
Yes.
That is awesome, because I didn't have that as a University of Maryland grad. Tell me what you cover. Like, what are the topics you have to cover while you're in classroom?
So you're familiar with Maryland's block system. So we have musculoskeletal block. So Roy Film is the block leader. Most things related to shoulder, knee, hip, he lets me lead the content on. So leading the lectures, leading the labs. I also lead all the imaging stuff. So I have a background in ultrasound. So I get to lead all that content, the ultrasound imaging lab. So that's the primary stuff I got to do. And then to fill my time, I kind of like pick up some anatomy, some of the basic sciences stuff, do those lectures. So to make sure I'm hitting my targets.
That's awesome. Do you do MRI stuff? You teach them how to read MR, X-ray, anything like that?
We go over MR and X-ray. Reading it, I feel like it's probably a little bit beyond entry-level PT, probably a little bit beyond like even mid-career PT, but just enough that T2, look for swelling that's going to kind of hone your eyes in. So we look at some stuff, but I'm not grading them on how they read an MRI.
Okay, and why are you teaching them ultrasound?
Because it's the best imaging modality out there.
It is, but what percent of your students do you think go on to use diagnostic ultrasound?
A small percent, but I think it gives you such a better appreciation of anatomy when you can look at things in 3D. Palpation skills we know are huge in PT. And then like whenever we do shoulder, I'm like, put your finger on the biceps tendon, ultrasound where you think it is and how close are you? Or even joint line at the knee. I have had people that be like, I've been doing this program for a year and a half. I haven't even been close to the joint line.
Yeah.
And that stuff is awesome.
That is awesome. And for many reasons makes me wish that was there when I was there. So that's awesome. Now, you're a sports PT, right? You're dealing with high-level athletes. Tell me what you cover sports-wise for the students.
Not a whole lot.
Why?
So it's everything we do is towards prepping the students for the boards and being a good all-around PT. So a lot of times I use sports cases as a good background just because when I talk about comprehensive sports rehab, you can go through the whole gamut. Maybe a lot of these people you see in outpatient clinic, you don't need to do the late stage rehab stuff, but I love it as a framework. When we talk about ACL, there's just the most research there. So I use that as a framework for all knee rehab. Even if you see a total knee, you're not going to do the change of direction agility stuff, but understanding the basics of how to get extension back, how to get quad back, that still applies to all knee rehab.
Yeah. Okay, so that makes a lot of sense, but you don't get into that end stage stuff in the classroom?
A little bit. So Roy's been good about giving us some time. So MSK2 is in the spring, we do more of the advanced MSK or musculoskeletal stuff. So he gave us like a 3-hour lab for testing. So we do isokinetic testing, isometric testing. We're bringing the force plates in. He let us add a 3-hour lab. A couple years ago, we did it on campus at UMBC. Let Brian, I mentor the strength coach, take the students through a workout, show them how to do that. I was on the field doing stuff on the turf. So we do sprinkle it in, but spending 6 weeks going through plyometric progressions, probably not a great use of time for every student that's in the classroom.
Yeah, and I guess that doesn't show up on the boards. If you had to design your own curriculum, Roy Film is not a thing. You're in charge. What do you change?
Whew. That's a big question there. I think I kind of do it the way I am now, where I use these big sport cases as frameworks. Like I always go to the example of the knee rehab. I'm kind of using like ACL as my framework of how to go through this early, mid, late, and then maybe touch on return to play. Like I just like chunking rehab into these phases, and maybe it's just like every body part is a phase rehab. Here's what acute rehab looks like. Here's what mid stage. Here's what late stage.
On all things. You do that for everything.
All joints.
Yeah.
When we talk about musculoskeletal orthopedic stuff.
So that sounds like you would not change anything.
Is that how it was?
No, it wasn't anything like this. There was no one that talked like Rob Rowland. There was no one like acted like Rob Rowland when I was there. So no, none of this was there. I'm saying what's different in Rob Rowland U versus what you have today at University of Maryland. If you could design your ideal ortho sports education, prep them to pass the boards, and prep them to walk into true sports and be ready to roll, what would you change?
Facilities would be a big one. So I think a lot of times we're limited. I talk about things so hypothetically, like here's how I would modify like this squat variation or split squat. If I had like a true weight room and turf in labs and like letting people get out, there's no better way to learn how to do stuff and program for other people than doing it yourself.
Yep. So
I think facilities is a huge problem. And I don't know many programs that have that kind of access. Like High Point, I know if you go on their website, they have a pretty high speed lab.
Bananas.
I don't know how many like DPT students are going in there and doing labs.
Yeah, I don't know. But you can't take them to College Park. You can't take them to UMBC. You said you did it once with Amenta, who's a stud.
Logistics is just like a nightmare, right? Like you try to get everybody, 70 students to come there and park, and then I'm getting emails like we don't know where to go, and then it's like the headache is just insane. So we take them over to URecFit, which is like a decent gym.
Yeah,
we can still get the same kind of teaching there. So we are improving like the sports stuff, and I just trying to make it applicable for every student that's in that classroom.
I will say, and I'm not saying this just because you're in front of me. It's crazy how much better the students at University of Maryland have gotten that we've been able to hire out of University of Maryland. We used to not be able to hire from University of Maryland because of their orthopedic outlook. So it's come a really long way. It's awesome. Are you touching plyos at all?
Absolutely.
Okay. So you get into that enough that they're able to learn. You wish you had more time to do that.
It's case-based stuff. So we have the ACL case, and I challenge the students in the class when we discuss it. What is a rational or a reasonable way to intro plyos, and then how are you going to carry that through a whole course of rehab? So we're talking about it, probably just don't have the space to get the boxes out of the hurdles and have people do the activities. You got to feel this stuff too to know how a depth jump is different than a squat jump. Like you have to do that stuff. And
have you had students come to you for their clinical rotations that were unprepared?
I think everybody's unprepared to some degree. So I get asked this all the time, and I'm curious your answer too. But like when people are prepping to come work with me, they always ask like, "What can I do? Should I sit for the CSCS?" And I'm like, "Sure, if you got time and money, go sit for it." But those letters don't tell me you know anything. If you can go volunteer and work with a good strength coach like an Amenta and just get some hours in the weight room, learn how to coach, like that stuff is great.
Yeah,
come with the soft skills. I should be teaching you the rest of the stuff. You just have this basic framework I laid out in the program, but you're going to get the reps with me, and I'm going to make sure you're doing everything the way you're supposed to.
And how many students do you get a year?
I take 3 full-time students each year.
Okay, so that fourth student that wanted to spend time with you, wants to go into sports after, didn't get a chance to be with you. What's your advice to them? How do they catch up?
I'll say, let me hit up Yoni and see if he's got a spot. I mean, we're in Maryland, right? There's so many great spots to get that experience. So there's, even if people don't get to work with us, like there's so many good opportunities to get good sports education around here.
Yeah. Okay. Then I want to touch on your other side of what you do for a living, if that's the education side. When you're rehabbing these high-level athletes who are either University of Maryland or University of Maryland, Baltimore County, talk to me about how you handle what I'll call the conflict of interest. You work for the school. Coach says, I need this guy back. You say, I need this guy back 5 months post-op ACL repair, something like that. How do you handle that?
As far as like coaches pressuring me to accelerate somebody faster than I want to?
Because my really, like, I see this all the time in the pros where it's like there is this conflict where it's the PT works for the team. His job is to get that guy on the field when the coach needs them on the field. A lot of times that isn't always possible. What do you do when rubber meets the road and the coach says, I need him on Saturday, and you say, he ain't ready?
Yeah, so I guess I have some protection that I don't work directly for the team, right? I'm hired under a contract, and I guess the coach didn't like what I was saying. He could say, let's get rid of University of Maryland Orthopedics as our provider of rehab. So I've never felt conflicted where I'm pressured to get somebody back faster than I want. I'm not saying that everybody follows my recommendation, because the surgeon's weighing in on it, the trainer, the sports med physician. So I always give my honest opinion. If that's always followed, I don't always have control of that. I'm on campus maybe 2 days a week. I'm just not there every day to give the green light, red light. I just give my recommendations, and I kind of have to take my hands off after that and be okay with that.
Yeah, I think that's a good approach. Okay, so you're in clinic with the Terps twice a week.
Yep.
How many hours, how many patients do you see in those hours?
So it's usually 2 full days a week. It's kind of fluctuated year to year. I mean, I've been there long enough now that my book is pretty big, so I could see 20 plus people in a day easily in semester.
So you see 20 plus a day. Tell me how you manage that caseload and provide high-level care.
So nothing is really done. I try to keep a schedule, but in this setting, it just doesn't work. People get out of practice early, get out of class early, and they just know, like, they know where to find me. So they come in, I check in with them, and then they kind of know what our plan is for the day. So there's no limitation. They don't have to be out of there in 30, 45 minutes. So I have a post-op ACL, and we have a big goal to hit. They could be with me for 2.5 hours. So I might have 4 or 5 other people rolling through in that time, but I'm checking with them. They're getting their lift in at the same time. So I really don't put a limit on how much time they're with me, because everybody's got to get all the work in they need. It gets hectic sometimes if I have 6 people there at once, but nobody, I would say, is getting short in that. It's a lot of late stage rehab, so I don't have to be hands-on walking everybody through these phases. What's
your best advice to the student that would freak the F out that they don't have a schedule? Like, how do they handle that? What's your best advice to them?
When I interview people that want to come with me, I just let them know I don't expect you to do that. That's just how I operate. So you're never going to see more than 1, maybe 2 people at a time, but don't be, if like the basketball guys coming in, there's 4 guys there all at the same time, making small talk, like giving everybody a hard time. And I'm like getting them going through stuff that can be very overwhelming. I had a girl the first day that like went to her car and like broke down. She wasn't seeing that. She was just observing me. She was just overwhelmed thinking she was going to have to do that. But I'm never going to throw students that. That's not entry level. That's absurd. Like you're probably going to go outpatient where you have people scheduled every 30, 45, 60 minutes. Yep. So I'm not throwing anybody into the fire. Like,
okay, fine. But how do you handle that? Like, what has allowed you to get to the level in your rehab process to handle that caseload? Give me some tricks.
I have a rough framework and plan of everybody that I know going into the day. That doesn't mean I chart review and write out athlete A is doing this, this, and this. I just know this person is this phase of their rehab. This is their focus. So those are the things I got to work on today. I know what they did the day before, so I got to progress something. And then there has to be some sort of intensity to the rehab. Like, as long as I'm checking all those boxes, they come in, they have a hard day, we're working towards their goal, then everybody is getting a good rehab session.
Yeah. I mean, I think that in and of itself, you belittle that. I think that's massive. The fact that whether you have to do like a full chart review or whether you have to write it out prior, it's that planning that goes a really long way. I also love that, I don't even think you realize this, but that you dumb it down to, are they in early, mid, or late stage? What is the goal of today? I know in my head, here are the exercises that will accomplish that. Go do it. That's a very different level. It's hard to get, I think, to that level. When I was at UMBC before you were there, dude, I'd been a PT for over a decade, and still, the night before or early that morning, I am looking at who I think is walking in and either writing, most times writing, here's what I'm doing with them. So that when they come in and I'm bouncing between 3 or 4 others, I'm like, hey, go warm up like this, then you're going to do this, then you're going to do this. If that bothers you, try that. I'll see you in a second.
Yeah.
Because that at least gives you a framework. And I think that's good advice for the newer grads. Yeah, listen, it's a luxury to walk into True Sports and you're one-on-one for 45 minutes every single time. Most places, it's not like that. And if you can function in a place that's not like that, one-on-one 45 is a dream. It's easy.
Yeah.
You know, so I think that'll help prepare. Okay, I want to get a little clinical. You've worked with tons of high-level athletes. We can get a little bit into your background because I think it's fascinating, some of the twists and turns to get where you are today, that it's worth highlighting. When an athlete walks in with knee pain, your favorite knee pain, what's the first thing you're looking at before you even start with your hands-on assessment?
So not touching the athlete, it's first thing is differential diagnosis, making sure that everybody who's coming to me has a diagnosis already. They've seen their trainer, they've seen sports med. I'm very confident in the team I have. But a lot of times, like, people's complaints change, symptoms change. So is what was sent to me what I'm seeing on the table? Are they describing is it a patellar tendonitis or like patellofemoral pain? Because I'm probably going to attack those a little bit differently. I got to be confident with that. Knowing their main limiting factors, like getting on the field, like people with knee pain describe very certain things, and that might dictate what testing I'm going to do. If they can't decel, then I want to know what their quad strength is. If they, as a basketball players, I don't have any bounce, then I want to probably do a drop jump with them and see where they're at side to side. And then the last piece of that is just overall rehab planning. So pretty much everybody that comes in, this is something I always talk about with the athletes, is plan with like the end in mind. What is the end stage goal? Is this somebody that's coming to me for 2 weeks and they got to start trying to get ready for season? Or is this somebody that's going to be shut down for 6 months? Because I'm going to attack both of those very differently. Then it's just reverse engineering from there and kind of chunking the rehab into pieces before that.
I love that answer because it's so heavily weighted on your subjective, right? Like your subjective has to be money and dialed in to kind of guide where you're going. Any questions that to you've seen seriously guide the direction that rehab goes? Like, I know I need to ask this.
When it comes to the knee, it's one of those, is like pain get worse the more you do. And I start thinking about more like sinister pathologies, like stress reaction, because those are going to be total shutdown. If it's like somebody like, yeah, it really hurts when I get going, but it has that warm-up effect, I'm like, okay, sounds like tendonitis or maybe some just general degenerative stuff. We're probably cool to keep pushing. Somebody that tells me their knee blows up after they do stuff, I'm like, okay, we probably need to look at this a little bit closer. So those are like the yellow, red flag stuff that kind of concern me.
What's amazing is all of that information comes out of one question, right? Which is like how your knee has been responding. And then that starts to guide you. I love that. I'm always preaching that every single word that comes out of your mouth should be geared towards building your spiel at the end of the evaluation. Like, how can I support whatever it is I'm going to tell you based upon all the information you're giving me? And if it's not guiding you there, you need to take that out of your evaluation, take it out of your subjective, especially when you're seeing a billion patients a day.
Yeah.
Right. So you got to get really tight. It's almost like writing this very long speech and then whittling it down until every single word is impactful. I think that goes a long way. I'm glad you think that way. Okay. How has your thought process around knee pain changed over the last 5 years?
Last 5 years is tough. I would say if I just went over my career, I'm kind of lucky coming out of Delaware that you were just hammered with quad from Lynn Snyder Mackler from the time I came out of the clinic. I think in the last 5 years, I've doubled down on like how important the quadriceps is and most knee rehab. Probably not all of it, but that's a huge piece.
When is it not? When's it not important?
When is quad not important or
as important?
Maybe in like a patellofemoral chondral pathology. It's important, but I'm not going to press on it as early because that can really flare somebody up. Like, I'm more patient with a quad in that case, maybe more hip dominant training. So that might be like something chondral in the patellofemoral joint, I'll probably be a little bit less quad emphasis early on.
Okay, because I was going to come back to, you made mention of difference between patellofemoral syndrome and patellar tendonitis or tendinopathy. Is that the difference in terms of the way you attack it?
I think in patellofemoral pain, or if there's like a large chondral defect, it probably needs a longer offloading period, maybe some different movement strategies to offload that area a little bit. Where patellar tendon, you probably be a little bit more aggressive up front where you can load that tendon directly early on versus like patellofemoral stuff.
Give me some of those other alternative strategies when you're talking patellofemoral in origin. How do you start? If you're not going to go right at quad, what are you doing?
So you're going to hit your functional patterns like your split squats, but it's more of that box squat, like hip dominant kind of patterns. Like knees still seeing load, but I'm not getting that positive shin and putting all this compressive loading on the patellofemoral joint. So if I can get there, I think that's a decent starting spot.
Yeah. Where do band walk and clamshells fit into this?
I mean, if you want to do it for a warm up, I got no problem with it. Like if the knee is so acute they can't walk, and that's their pain-free loading, then fine. But I think if you talk to any athletes I work with, like rehab with me it's a training session. Like you could do band walks and clamshells as like your warm-up or some accessory stuff, but it's not training.
Yep. Training would be more of your squat pattern.
Yeah, we got it. There has to be some relative intensity. You should walk out of rehab. If pain is not limiting you from doing most of your things, you should walk out of rehab feeling like you got a really hard workout.
Yeah, I love that. You should work at True Sports. Where does manual therapy work, or where does it help and fit into your treating algorithm?
So if you've listened to me talk, it sounds like I don't do any manual stuff. I think putting your hands on people is really important, or else like how are you differentiating yourself from the strength coach? Not that we have to, but there's a connection that's built there, right? So everybody that comes in, even if I know their knee is good, I'm going to look at swelling. I'm going to look at knee extension, check knee bending. I might not even get like a lot of info from it, but at least that athlete's okay. Rob's looked at my knee. He's helped me a little bit with that. But then if like knee is stiff or they're feeling a little bit achy, maybe some patellar mob, some extension stretching, some soft tissue on the quad. Like I got no problem with any of that stuff as long as it's getting towards this goal of loading their lower body.
If you had 30 minutes with a patient, would you still put your hands on them like that? Are you still doing patellar mobs?
If it's 30 to 60 seconds, sure.
Okay, it's quick. You're not spending a bunch of time. And your goal there to change the patellofemoral mechanics, or is your goal to become the best friend of the patient that you're touching?
Well, I don't want to be best friends with anybody, but I want to build a connection, right? There has to be some kind of therapist-athlete relationship. And if I'm just moving their knee and just asking them how the weekend was, like that's just an opportunity where it's just like, we connect for a second, we have a good baseline for the session, we can kind of build off of that. Whether the patella and mobs do anything, it's probably less important than just like that connection with that athlete to start the day.
Is there any manual therapy intervention that does help heal the patient physiologically for the knee?
Not that I know of. Do you have one?
I don't. And dude, I just listened to, I forget her name, in Aussie talking about patellar tendinopathy and the fallacy of cross-friction massaging and like what we thought it did and what it actually does. And I've come a long way away from the Graston technique purportedly breaking up scar tissue. I think that's a bunch of freaking eyewash, as my baseball guys would say.
Yeah.
But no, I don't think we're healing anything when we put our hands on them physiologically.
So do you do manual therapy, or do you just throw out the Graston tools?
I don't use the Graston tools. I really don't. I'll do retrograde stuff if the knee's really swollen.
Yeah.
I honestly believe that athlete is getting far more psychologically than they are physiologically.
And I think that's important.
Yeah, it is important. It's really important. It's 90% of the crap we do. Can you do that when they're doing band walks? Can you do that when they're on the Aerodyne? Yeah, you can. And I think like you're seeing our profession go that way, where it's like that stuff just isn't as important. It's also like I'm working with a linebacker now who just came up from Houston because his knee's not where it wants to be. His take on our sessions, like his feedback to me is, I come to you because you obsess over the details of every single exercise we're doing. Not, I come to you because you put your hands on me.
Yeah.
So when you talk about the difference from a strength coach, as awesome as a Menta is, he's just not one-on-one obsessing over the details because he doesn't have the time to do that. Not that he can't. So I think that's a big differentiator. I don't want to like throw that out that like we have to put our hands on our patients to differentiate ourselves from strength coaches. I think there are other ways to do it is all I'm saying. Okay, talk to me. Let's go a little bit force plate, okay? Because Dr. Jay Hammond and the soon-to-be Dr. Kevin Lynch said, you got to hammer this guy about force plates.
Brett didn't say anything about force plates?
Brett didn't say anything about force plates because I didn't.
It's too many numbers for him.
I wasn't in the clinic long enough to get it from him because I don't go to Columbia enough. So tell me where force plates entered your consciousness and when you use them.
Entered my consciousness years ago. So I was working in a tactical setting, and these special ops contracts, your budget is limitless. So it's like you hear about a tech, let's get it and see what it is. So we bought force plates. We used them a couple times, then they sat there. We had a guy that we did a counter movement jump, blew his Achilles. We looked at the data and we're like, don't really see much. And just the athletes we were working with are tactical athletes. It didn't really have much implication in what we would do. So they kind of just sat there, took this job at Maryland. I don't know when College Park got him, but it's been a few years. UMBC recently got him. So
what do they use in Vald?
Everybody uses Vald.
We just went in with Hawken.
How was that?
So first we had Vald to start. First I got Vald in our busiest clinic. I swear I was the only guy that used them.
Yeah.
And they just collected dust, like you were saying. We're talking like 7 other PTs are just walking by him every single day. And the reason that happened was the learning curve was massive. It was massive.
Yep.
Then a lot of this is on us. Like then we got another pair of Vald and put it in a different location. And we tasked one PT, Delaware grad. You are our force plate queen. You learn how to do it, then teach everyone else. It made it a lot easier. I found the software, except they just did a recent update, which I think totally changed the game for them. Still, it was too much information. Vald wouldn't just tell me, give me 3 tests. I want to know what these tests show. I want to know what I'm looking for. I want to be able to compare it to athletes of all different levels. You have all that data. Make it simple. They just didn't make it simple. Hawken makes it effing simple.
It's good to hear.
It's also the tech with Hawken. First of all, the plate is bigger. So that's just more comfortable to the athlete. It gets far less misreads. I just think it's more consistent, it's more accurate. The interface is a lot easier. So I've been really happy with Hawken. But you're right, Vald is all over the place. Okay, so you get Vald at University of Maryland.
Yep.
And tell me how it's used.
So it's mainly performance staff that uses them. And depending on the team, it's different how they use them. Some teams just do some preseason testing, postseason testing. Other strength coaches will do weekly monitoring on their athletes. And then the rest is kind of like just there for us to use if we want. So I just took the initiative. If we have these force plates sitting here, I'm going to use it for any person that I think I can. And at first it's just collecting data, right? I'm just using it like a jump mat or just like a measure for jump height. And then the more I look at it, it's just like, all right, here's a new variable. Let me just start looking at this. I'm not going to talk about the athlete and just slowly learning over time, like how these variables change, which ones are meaningful. And I still don't know if I have a good answer to all this stuff. I don't know if anybody does, but it's just using, you just have to use it and look at it.
Yep. You have to use it. You have to look at it. You have to be humble about it, that you're not a sports scientist yet. So I think that goes a long way, but you got to have some answers for me. Like, what are the KPIs you look at? What pathologies do you say, I need to get this guy on a force plate?
So it's less about pathologies, certain complaints. So if a basketball player tell me he lost his bounce, then I'm for sure doing drop jumps with him. And I'm going to do single leg drop jumps because that's almost 100% of the time I see a huge deficit that like links up with exactly what they're telling me. Other piece of it too is like I always use Al Vermeil's like hierarchy of performance. So it's bottom of the pyramids, like work capacity.
Yep.
Above that is strength. I feel like that's what we spend most of our time in rehab doing, is building strength. When I have somebody that's like hit those 2 buckets, explosiveness is next, and force plates are my best way to test that. So it's just a way for me to objectively track where somebody's at and get them to buy in with that. So I don't do a lot of CMJ or counter movement jump. I might look at that like relative to a squat jump to get like an eccentric utilization ratio. I think those numbers are kind of interesting in like volleyball or wrestlers just to look at. But single leg jump, single leg drop jump, those are like my money tests that I use for the force plates.
Okay, and why don't you do single leg CMJ?
I do single leg CMJ.
Okay, you'll do a single leg CMJ. You don't see much value in doing a bilateral.
There's value. I get more data out of this single leg stuff. I'm looking for low hanging fruit, big obvious asymmetries. I don't care about these 10% like fluctuations, but if you see a single leg jump and somebody's counter movement depth is half of what it is on the other leg, their eccentric peak velocity is half and their output's a quarter, like that's easiest buy-in for the athlete. They're like, they can see a 40% deficit on my computer and we're going to track that every week or every other week. And then you just have them bought in. It motivates them. It makes total sense.
Okay. Love that. Tell me, once you see those deficits, you see the drop in depth, what do you do? How do you train to make that better?
I think this is an interesting conversation to have. Do you train to the force plates, or are the force plates just a proxy for like good rehab? Like, do I just do good training and watch the numbers change? Or I don't think I really try to rehab according to the specific variables I see.
I mean, if you have a deficit in the depth that they're falling to and exploding out of, that's telling you something and will gear your input, right?
Yep.
So if you're seeing those metrics or a deficit there, how does that change your exercise prescription?
So we'll use the single leg jump or single leg CMJ.
Yeah.
Where say they're moving, the eccentric peak velocity like is usually 0.8 meters a second. If I'm not seeing somebody move that fast into their eccentric, they're really not doing a single leg jump. And then I got to ask myself, why are they not moving fast? Did they not have the range of motion? And do they not have the range of the knee, hip, or ankle? Like those are things you got to tease out. Are they scared to move? Is it the first time doing it? They just don't want to move fast. Have they never single leg jumped? They just don't know how to do it. Or do they not have like the eccentric strength to stop themselves from descending? So it's your clinical assessment has to match what you see in the variable. So it's not just I see slow eccentric peak velocity. So we just do a bunch of snap downs.
Yep. Okay. So tell me that's an awesome answer. Tell me how you tease those out.
So if it's range of motion, you just you're not going as low. Let's just do knee to wall test and do a quick screen. Is that side significantly limited compared to the other side? Well, we work on that and then retest. Does it get better? Then that was probably it.
Yep. Okay. So that's your ankle deficit, right?
Yep.
What deficit would be transpiring at the knee? They definitely have the range of motion of the knee.
Yeah,
right?
Range of motion is not going to be
the issue.
You would have caught that. Let's say it's an eccentric strength issue. Yep. I'm not going to pick that up with like an isometric test with like an inline dynamometer. So maybe just doing like a goblet single leg squat to an AirX on the ground. I love putting people on a ramp, just seeing how much load they can lower down to the ground. And if they can go body weight on one side, but can hold a 50-pound dumbbell on the other, well, we just got to build some eccentric capacity.
Yep. Okay. Love that. Let's zoom in there. What are your preferred exercises to strengthen them eccentrically when you find that deficit?
If I have access to a full rack, I love safety bar and doing all kinds of Hatfield variations. It's safe enough that I can walk away from somebody and know they're not going to pin themselves to the ground. So safety bar, Hatfield variation, single leg split squat.
Tell me what that means. Tell me what a Hatfield variation is.
So safety bar sits on the shoulders. I don't have to put my hands on the bar. It's balanced there. And then you can either grab the rack or grab some pins in the rack. And then I have some sort of stability. So I can lower down and then I can use hands to pull myself back up and help in the concentric. So that's like a super easy way for me to overload somebody eccentrically. Like the K boxes, we have those are cool, but I just don't trust them. I think that is like challenging for me to use and it kind of pulls me through the ground. There's not a lot of athletes that have a high enough training age that I feel real confident telling them to do something on there and then turning my back on. That's a little scary for me.
Take my K box off of my wish list. That's what you're saying. Okay.
They have like K box knee extension machines. I never use one of those. I'd be really interested in that, but like there's too many degrees of freedom in the K boxes for somebody to squat and split squat unless there's some constraints in place where I can really trust them to push the intensity on it.
Anything else to hit their eccentric control or strength?
I mean, any of your 2 up, 1 down stuff. So leg press and knee extension variations. If you got one of those MVP shuttles, any of that stuff that's safe and you can overload. There's like stability shouldn't be the limiting factor. It should be what can your knee tolerate lowering to the ground.
Okay. So love that. But what if their issue is stability? How do you tease that out? Because that could be the reason that their single leg CMJ sucks.
Stability in the sense of like balance, or
Yes.
I just don't know if I buy that very much. I don't know if I've had very many people where it's like your balance is so bad that we just need to put you on an AirX and do 30-second holds to work on your stability. Maybe yours is different. That's one of my biases. I just don't see a lot of value in the stability training.
Okay, so you're assuming that that's not the issue. You're assuming it's a strength deficit. And then just real quick, where are you with open chain versus closed chain when attacking this deficit? Because you picked the deficit up in closed chain.
Yep.
Does that matter?
I think it does. You want to be as specific as you can to that. But if, let's say we do that eccentric single leg squat and they're collapsing so early, they're not getting a good training effect of it, then maybe we need to supplement with some open chain stuff, or they need to do open chain for a couple of weeks before we can add a closed chain variation.
The points you're making in all of your answers are that all of your interventions should have a rationale behind it. It doesn't necessarily have to be the right rationale, but there has to be a reason you're choosing them. And I think that's the biggest takeaway to the listener, especially the rookie listener, but even someone who's doing this for a while who doesn't necessarily have that mindset, is you're choosing a Hatfield because you're eliminating the stability. You're clearly attacking their deficit in a closed chain format. That's why I asked you to really go in depth of what a Hatfield is. You're not worried about the stability, and you're putting them in a leg press or a shuttle because you think that this is purely strength. That's why you're choosing those things, as opposed to the other possible variables, like you mentioned with the K-box. So I think that's the gold in what you're saying. I know it's simple to you, but it's worth like fleshing out.
You sound like me at the end of the day with all my students, and it's just everything you did, tell me why.
Yeah.
And it doesn't have to be right, but you should be able to justify it, and you should be willing to change it if you're wrong.
Yeah.
And you got to reevaluate that every time you see somebody.
Yeah. Yeah. I love that. Do you guys have shuttles at?
Yeah, we do.
That purchase, I have one of them in our 15 clinics. That is my favorite piece of equipment. It was like my dream coming out of the first place I worked. I'm like, what is this machine? I got to get one of those. They're a goddamn fortune, but they're awesome.
What's the retail on a shuttle? I have no idea.
New?
Yeah.
$6,000 to $7,000.
Wow.
There was a long time that it was more expensive than the car I drove to the clinic.
Wow.
Yeah, it was like, and I found it used for $5,000. They're bananas. I know, but they're awesome.
What's the upkeep like? How often do you have to replace the bands?
We put a lot of patient on ours. We've probably had it for 7 years, and I've replaced the bands once. And by I mean our clinic director has replaced the band once. So yeah, they're solid, and it was used. Makes some weird noises. Nothing WD-40 doesn't help. So yeah, I highly encourage the shuttle. Shout out to Perform Better, I think they make it.
They sell everything.
They definitely sell MVP. Okay, hip. So they do their CMJ. How are you going to tease out maybe this is a hip deficit, either range or strength?
When it comes to the hip, to me, a lot of times it's like, do they have the control? And I don't have a great way to objectify that. If I have motion capture on top of the jumps I do, I think that would be the next level. We've like looked at, I think Dari's like the markerless motion capture, but it's so expensive. The setup is just insane. We'd have to have a lab space committed to it, but for the hip, I'd be really curious, like what the actual moments are, like the hip extensor moment is, and then getting some numbers on like the frontal plane movement.
Yep. Right now, what do? You eyeball it?
Yeah.
Okay. So they have a serious lateral shift as they come towards the bottom of their CMJ. You think that it could be one of the reasons they're not dropping to the depth or moving at the speed that you think. How do you attack that deficit?
So they're getting a lot of medial collapse. We think it's coming from their hip.
Correct.
So I'm probably going to go back to the hierarchy and look at strength of lateral hip. Do they have the ability, the capacity there to even stabilize against
that? How do you test that?
Side lying hip abduction. We can put them in a force frame and just do a gross abduction test. And everything I do strength test wise, I try to normalize to limb length and body weight when I can. I think that just symmetry is great. It's so much better than what we do. But if your overall output is shit, then I don't really care if you're symmetrical. Like you have to be able to have good output. So
handheld dynamometer for that?
Force frame if I have it, just because the setup is so much easier. Like I told you, my schedule is very busy. So if I'm going to do a strength test, I got to get it done in a couple minutes. I can't get a handheld out, lay them on the table and try to standardize or like set up an inline test. So I'm always about like the quickest, most reliable way to get the numbers I want.
Okay. So you're making the case for manual muscle test?
No.
Okay, you're making the case for what? How are you testing that?
Force frame. It's just
you're putting
it's
them
an
in a force
isometric
frame.
dynamometer that's
Dude,
already set up.
No one has that. I mean, all the colleges have that. All the teams have that. I am not interested in buying a force frame for my clinic.
So you just go down the rung. What can I do? Manual muscle test is probably not great, but at least like a single leg side bridge, I can get an idea. Do they have the capacity that are at least stabilizing against their body weight?
Okay, I like that. And then if they don't, you're identifying that as a weakness. Your therapeutic exercise looks like what? Tell me how you attack that deficit.
In a case like that, if we want to be specific to the single leg jump, and now we're assuming that having like a really good single leg jump is like what we need to have. That's just a proxy for
Fair.
single leg power. But
Fair.
like a single leg landmine deadlift or like that squat deadlift variation is, I love that just because the way your body's set up, it causes like this big abduction moment. So you got to work hard with your abductors. There's stability of the landmine setup. So to me, that's just like a really good way to kind of bias the hip with a pattern that's similar to the single leg jump.
Okay, I love that. That's a great answer. Give me another one.
Man,
So good. That's a great freaking answer, and why you would choose that exercise. And as the clinic owner, I love that because it doesn't cost anything.
Yeah. Isometrics are huge. So putting people into these jumping positions is just trying to bias the hip, whether that's with an external load, a band, jumping variations in frontal plane. You're probably going to get a little bit more hip. So like just some single leg line hops, can they do that motion without a lot of knee bend and like get good hip stability? Then that's going to give me more ideas of where I need to go to kind of build this capacity.
Yeah, I love that. Is there any likelihood that someone with knee pain, a crappy ass single leg CMJ, has a posterior chain deficit or a hamstring deficit?
What do you mean by a hamstring deficit?
I mean, their hamstring's weak.
Maybe, but if their hamstring's weak, they're probably, unless they've had a hamstring injury, I would guess they're kind of weak everywhere, and their overall don't have that strength capacity, and they just need to build lower body capacity.
Yep. When do you, in a knee pain patient, whether it be patellofemoral, whether it be patellar tendinopathy, whether it be ACL, when do you start to isolate or load heavily the hamstring?
So is this a hamstring graft?
No.
This depends on the person. So most people that I'm seeing, they're going to be training with their strength coach anyway. And it's how many lower body, like hamstring specific touches are they getting in with their strength coach? If they're getting 3 lifts a week and they're hitting 1 or 2 hamstring things a day, then I'm probably not going to add a whole lot of supplemental stuff. I'm going to try to be very specific to the knee. But if it's somebody that I see their team training and I see the intensity of their lifts, they kind of just hang in the corner and don't do anything. Maybe we're going to do one exercise with 3 hard sets to make sure we get some hamstring. So it's very case dependent, but I want to be as specific as I can to the deficit that I'm seeing. You
also make the point that an outstanding physical therapist is an outstanding strength coach, and you need to understand the programming, the different cycles they're in, the periodization, so that you can either have the conversation with a strength coach or understand where maybe some of that programming needs to be supplemented or augmented. So I think that's a great point in and of itself.
The programming piece is huge. But the other piece of I think what strength coaches do so much better than PTs is coach. Like a good PT has to be able to coach. And I think I coach a specific way. You probably coach in a certain way, but that's another thing I get on students about is you got to find your coaching voice. You can't sit in the corner on your computer and write your notes. You got to get in the weight room and find how to motivate that person that's in front of you. You probably got to change it based on the person you see, but learning how to coach. If I do anything well as a PT, I think I'm a really good coach.
What makes you a good coach?
I think I understand what motivates people, and I can kind of connect with each person and meet them where they are. There's people that are high anxiety that I can't really scream at, but I can also go in the football weight room and scream at a dude squatting while the music's blasting and get him going through a session. So I can kind of adapt to the person that I see.
Where did you learn that?
Just reps of doing, right? I'm a meathead, so I love being in the weight room. My wife is one of the best strength coaches in the best strength coach in
the world.
So I learn from her. I see how she does things, and I've probably picked up a lot of dealing with female athletes from her because that's a whole different dynamic. If anytime I do isokinetic tests, I'm usually screaming at that person. But now if I see The female athlete that's like a little bit quieter, I'll ask them, like, what are you gonna, if I start screaming, are you gonna like laugh or like shut down? And they're like, yeah. Well, I'm like, okay. I look them in the eyes. I'm like, I need you to kick as hard as you can, and I won't make a scene in here at all. So you just got to understand that person. That goes back to that 5 minutes at the start of the session, like learning about them.
Yeah. So that's one part of coaching, is the motivation side. The other part is cueing and getting the desired effect. How would you describe your ability to do that?
I think it's pretty good.
I'm sure.
I don't rate
it's
myself
great,
high on it.
No. Listen, I'm sure it's great. You're working with high level athletes. I see all your students. They rave about you, and your athletes get better. So I know it's great. But how would you describe the way you cue it? The way you cue an exercise, how you get the desired motion or movement pattern that you want.
So anything I do with that athlete, I have an intention for that activity. There might be 3 or 4 intentions, but there's one primary one. So it might be telling that athlete, we're going to do this activity. This is what I want you to feel. This is what I want you to get out of it. So we have that baseline established.
Give me very specific. Let's go back to the knee.
So we're doing split squats. I want you to feel this in your quad. Like, I need to feel burning your muscle. If you feel like some noise in your knee, that's cool, as long as the volume in your quad is higher than the knee. That's our baseline. As we start doing it, are you feeling anything there? Is our warm-up set? They're like, no, I don't feel anything in my knee. So do I give them a cue? Do I tell them to push their knee further forward, get their chest back? Like, you can just look how the person's moving. Maybe you pick one of those. And then if that doesn't work, then you put a constraint in place. Maybe I put something under their heel, have them go arms above head, hands behind head. Just pick one thing at a time and just going back to that anchoring activity. Are you feeling this in your quad?
Yeah. You always give them the answer to the test before they take the test? Or do you wait for them to take the test, do the exercise, and then say, where did you feel that?
Probably depends on the person. The higher anxiety person, we're going to talk about what my expectations are. The juggernaut is going to run through a wall, do that activity, and then I'll check in with you after. Once you check in for the set, do your work, and then tell me the response.
Yeah. You know, I have a couple patients now that we're talking about understanding that patient interaction that will not answer me during a set. So set of 10 at rep 5, sometimes I will instinctively say, where do you feel? You feeling that in your quad? They just don't respond. But I put that in the back of my head, and like that becomes their profile. I don't talk to them until they are done. It's all about like building these different archetypes of patients and figuring out like, hey, I remember the guy who also didn't talk in the middle. Let me see if this guy's a talker in the middle. I'm going to relate to him the same way I did like to that guy 5 years ago. So I think they're different strokes. When you have an ACL, like one of my biggest challenges in ACL rehab is, can you feel your quad working? That quad just freaking goes to sleep. What are some tricks to get that patient to feel it in their quad other than push your knee further forward?
So this is the time you pull in the open chain exercises, right? You can't do a knee extension without working your quad. So if I have a knee extension, I'm going to start there, and then we build off of that, right? So maybe like this, it probably goes against most strength and conditioning theory, but maybe we fatigue with knee extensions first and then go into our squats and split squats. So we have this anchoring to, you feel your quad, now we're going to do it in this exercise, we're going to do it in this, and then we'll finish with some sled drags till your quad is completely depleted. Mm-hmm. Then we have this baseline session we can go off of, and that's what we should be trying to go for.
You ever use stim in this world?
Just a little bit.
You do a ton of it, huh?
Ton of stim, yeah.
Okay, so talk to me about where PTs are too commonly underdosing the use of electric stim.
I think the thought with stim is it's just to warm the quad up, get people feeling their muscle. But if you look at the research, we're supposed to be doing it at 50% of somebody's max volitional isometric contraction. And if you've ever hooked yourself up to an isometric machine and tried to turn stim up to 50%, you have to be a complete masochist to get there. So I don't think I can get there. It's very uncomfortable. So again, talking to that person and being like, I need you to push as much as you can in the stim, and then I'm going to turn it up 3 more notches. If you need to kick with it, if you need to bite on a towel, whatever you got to do. But there's enough research out there to show that this is really important. And we're going to do this until you show me like a 70% quad index.
You sound like a Delaware grad. Okay. How often are you going to that level, or how early are you going to that level with stim?
So once they can tolerate being in an isometric knee bend position at the edge of the table at like 70 or 90 degrees, then I'm going right to it. Before that, when somebody's like in a straight leg position, I'm probably not going to turn stim that high because they might cramp up and fall off a table. So I'm a little bit nicer there. But once they can, I trust them over the side of the table in an isometric position, we're ramping up that stim.
That's awesome. You ever use it in the straight leg raise world?
I do, but like I said, somebody has an extensor lag and they're kind of stuck with that position. I think that's totally fine, but you're probably not getting the same adaptations you get at the edge of bed setup.
Is the adaptation hypertrophy or connectivity, like activation?
It's probably a little bit of both. Probably not much hypertrophy if we look at like there's probably not enough mechanical tension.
Yeah.
But there's other benefits there, and you're getting this reverse recruitment of motor units. So we're getting the big fiber motor units. We're probably not getting that with the squat or knee extension until a couple months out. Yep. So it's the only way we're stimulating those fibers, that and BFR probably.
Okay, so that's my next question. When does that enter your world? And walk me through various pathologies. When do you use BFR that it's a no-brainer, we have to be using BFR?
I probably don't use BFR as much as you think I would.
You have no idea how much I think you use BFR.
How much do you think I use BFR?
I think you never use it.
Okay, I use it more than you think. So it's great if you look at the research for preserving muscle mass. So I think it's really important in the acute phase. Once I'm not worried about wound infection or dehiscence, we're putting BFR on, even if it's a very low load exercise.
What is dehiscence?
Opening of the wound.
Okay, thank you. Okay, so as soon as you're not worried about that, you're putting a BFR for any exercise that you can. Straight leg raise, knee extension, whatever it is.
I'm probably going to pick the easiest exercise that isolates the quad the most. One of my pet peeves is when I see people in BFR on and doing step downs and squats, and they're doing these like just the ugliest step down you've ever seen. I'm like, the whole point of BFR is to get very local load on a muscle. So knee extensions, this is Brett's favorite, is manual resisted knee extensions, because now I can control intensity. Yep. And I can be very specific with the muscle I'm loading.
Yep. Okay. So you're going to that early. When do you go away from it?
Once I can tolerate high intensity loading, and I'm not necessarily going away from it, I'll always pull that back in. Maybe that's the thing. That's our finisher, is BFR. Some people just love it. One of my other biases or things that I believe is there's definitely the specific effects of BFR. I think BFR teaches intensity to a lot of people that have never pushed hard.
Yep.
Because they don't need a heavy load. All of a sudden it gets to this point where they're getting like pretty close to muscle failure and can't move their leg. They've never pushed themselves in a context like that. And they're like, oh, this is what hard training is supposed to be. And I've had multiple people that like after that, they'll be doing knee extensions and they're like, I feel like I have BFR on right now. I'm like, yeah, heavy training is going to cause an occlusion effect. Like that's an awesome link you just made there. Now you don't need the BFR. You just need to train heavy.
Any other mistakes other than doing like a more functional pattern that they can't do well and doing it with BFR? Any other mistakes you see people do you committing with BFR on?
I wouldn't call it a mistake, but everybody just kind of goes to the default 30, 15, 15, 15, yep. Which if you follow the essence of the protocol is great. Like I tell people the first 30 should be hard. The second 15 should make you question why you're doing it. The next 15 should feel like you're going to fail. And then the last 15, you shouldn't even want to like move whatever limb you're doing.
Yep.
If you're getting that intensity, that's great. I usually don't use that protocol. I just tell people, let's do 3 sets. We're going to push to an 8 RPE in the first, 9 in the second. And the third one, you're going to leave everything on the table, like until you can't move your leg. So I think that intensity piece is everything. The reps don't matter as much.
Okay. What about strength of the BFR or occlusion?
The research shows us like 80% for the lower body is better. Maybe higher is better, but I think I could put somebody at 60% and just push the intensity a little bit with either reps or weight and get the same effect.
Yep. Okay. I think that makes a lot of sense. Okay. Man, like you said, you had when you were working with the military, an unending budget. So you probably saw some of the future of where our profession is going. What do you think is next?
As far as like technology in the PT space?
Yeah, anything in the field.
I mean, anything I've come across, it's cool to have. And I always go back. I gave a talk at CSM like years ago, and I was really focused on musculoskeletal ultrasound. And there was a guy in the crowd that I know. He's kind of like a troll. but he's kind of like, could you know what you know about ultrasound now? Could you do your job without it? And I was like, no, this is great. Like it's awesome. But like, I think later that day I'm reflecting on, I'm like, I could do my job in this room. And I think I could do 80% of what I do. So any of the tech is like cool to have. The force plates are cool to have, but I could do the same thing without it. You don't need any of these fancy tools. So there's nothing I've seen out there that's like critical. This is going to change rehab. AI is like probably the most emerging tech we have. And that's probably going to level the playing field with knowledge. But what's going to differentiate people is the other stuff we're talking about, these soft skills. Like, how do you coach? How do you connect with the people that come in the door? That's what's going to keep people coming to you when we get to this age where information is just everywhere.
I think you're right. I also think it's the application. And I think you can get some of that from AI. I just like, these are the deficits. What do I do? I think where it's not going to help us is inside of this squat when they're doing their stationary lunge and they're not feeling it in their quad. How do you get that from them? AI is not going to be able to help you with that. And I think that is the number one differentiator of what makes a good PT. And I would argue a sports PT from a standard general ortho PT is how do you get the desired effect out of your patient in them in real time? AI is not there yet to help us with that. I don't know how that would be or how it would, but I think that's what's important. I always think about, you mentioned Dari. In 2012-ish, there was an NFL work stoppage. So I quickly picked up the phone, called the Ravens training staff. I'm like, hey, can I come in and, meet you guys and treat your athletes? Because you're not allowed to treat the athletes. They're like, yeah, come on in. Because they had literally nothing to do. There were no players. I walked in and I'm talking to this guy who's probably in his mid-60s. And I'm like, whatever. I'm trying to impress him. And I look in the corner and there's a giant computer and a stack of papers. I'm like, what's that? They're like, oh, that's the Dari system. I'm like, what's Dari? Tells me about motion, markerless motion capture, all of the information it can give you. I'm like, how do you guys use it? They're like, yeah, we don't use it. And I'm telling the story because it doesn't matter how much tech you have if you don't understand how to apply it, how to use it, who it's applicable for, et cetera. How do you then go back and retest and make meaningful change? Like you say, are we rehabbing to the test? Are we rehabbing to the athlete that's in front of us? I think that is a massive game changer, like a mindset necessity that you have to have when treating these athletes. Is there any tech that you wish you had in College Park that you've seen elsewhere?
The markerless motion capture, if it was set up and easy to use, I think that adds an element to the jump testing we're talking about.
What's Perch do with that stuff? Does it give you any of that?
I don't think so. I think it's just speed of movement stuff. And I know what Perch is, but I haven't used it. So maybe they've upgraded and they do some markerless motion capture. I don't know.
Okay.
There's some like fancier isokinetic machines I've seen coming up that are kind of like Smith machine applications. And that'd be cool to have a place where I could like do some force velocity curve profiling people in a space that would be kind of cool to have. But again, I don't know how it's going to change what I do day to day. It's just getting more data. And a lot of times just more data ends up being testing time that I'm not training people or rehabbing people.
Yeah. Now you mentioned, like the fear of training to the test with the force plate. How do you get away from that? How do you make sure you don't fall into that pitfall?
So the test I probably repeat the most is a single leg drop jump. So I kind of go back and forth on this one because the other thing I tell people when they're learning force plates is don't just look at the numbers, look at the force curve. You learn a lot by seeing like how somebody generates force. And one of the pearls I have for people looking at single leg drop jump is look at that curve. Is it like this very skinny parabola where they just hit the plate and bounce? Or do you see like this double peak? To me, that double peak is either knee flexing if it's kind of soft, or if you see a sharp peak, that's like ball the foot hitting, then heel crashing. Mm-hmm. So if I see that heel crash, can I just do some like ankle strengthening, some ankle stiffness, like iso drills? And does that get the test better without doing the test? Instead of just having them do a bunch of like single leg drop jumps or reactive jumps, can I just train the ankle and limit the impact and get that test better?
Mm-hmm. Mm-hmm. That's a great way to look at it. Lightning round, Rob Rowland.
Let's get it.
Why do you not work in private practice?
I think the thing I like most now, what I do is 100% of what I see is D1 athletes. I can literally walk out to the field with them, and I don't have to do any marketing. They have to they come to me. If they don't want to see me, they don't have to. It's no stress. I don't have to go visit anybody and say, send me patients. It's
anything you wish you had from the private sector?
Space that I can control. Like there's too many times where team's practicing or team's lifting and I got to change my plan on the fly. Like I would love to have, this is my space, the testing, the force plates stay here. They don't move around. So I get quality data. I want to know I can do what I want to do that day.
Rob, I can give you that. It's easy. That's your only demand? Okay. Social media. You are insanely well-read. You know literature like the back of your hand, inside of your eyelids. You are not active on social media. Why?
2 reasons. One, way back in the day, Mara told me Instagram was just for taking pictures before you go out. So I said, okay, I'll never get on Instagram.
Okay.
2, I don't know. I don't feel like I need to share. I share with the people around me. I like keeping a close network. I don't need to put any of this stuff out there. I'm not going to like pimp athletes out and put them on my Instagram being like, look how great this person is doing. And like, I don't want to like act like I'm taking credit for that. These athletes are who they are because of who they are. If I could help them a little bit along the way, that's great. But I just don't want to put that stuff out there.
That's another positive to be in academia. Like you don't have to do that. It's a must in the private sector. So add that to your list. I think that's an answer. So was that 2? You said 2 reasons.
Mara. And then my actual
and
reasoning.
Actual answer. Okay. You tear your ACL, God forbid. Who's doing the surgery? What graft are you getting? Who's doing the rehab?
I'd probably go to Sean Meredith. I think he's very talented.
Great hip guy.
Awesome hip guy. I like him as a person. Not that should dictate who you go to as a surgeon. I think that's a crazy reason to pick a surgeon, but
it helps.
It definitely helps. Graft, I honestly might do a cadaver graft.
Why?
What I see is graft site issues are the donor sites are like the cause of a lot of issues for people. And I don't want to have anterior knee pain for patellar tendon, like causing me not to squat after surgery. And I'm in no rush to get back. So if it takes a year and a half before I'm cutting on it, I don't care.
What are the chances that it re-ruptures?
Probably higher than if I had my own graft. But I'm not doing a lot of risky stuff. I'm not playing.
You'll just do it again. You'll just do another cadaver. If you
there you go.
Who's rehabbing?
Honestly,
I'm free on Wednesday.
This is me being very stubborn. I'd probably do most of it myself.
Rob, you have to choose someone to rehab you because you're going to be soft. You're not going to want extension. You're going to keep it in a slightly flexed position. I know you, Rob. Someone's got to push it into extension.
See, now I'm going to pick somebody. Everybody's going to know who my favorite student is, so I can't pick any of them.
Oh, it's going to be a student. Okay.
Well, I only know so many. At least I know I trained them, so they're going to know how to handle it. Me.
Okay, who is it?
We'll go recency bias. I'll pick Brett because I know he's
Brett Rayner.
Yeah, because if he tells me to squat, I know he can squat double what I can. So at least I got something to push for.
Have you ever seen a front squat like that?
I've never seen a specimen like that. So one thing I do with most of my students that can is we run stairs at the end of the rotation, just in the football stadium. I always go first because I can set the pace. I know nobody's going to catch me. When I did it with Brett, I was like, all right, you just go. He's like, even aerobically, he's an animal. He attacked those stairs like he was eating them for breakfast.
How did his college football career end?
You have to ask Brett. I don't know.
The numbers he puts up in the weight room are bananas, and the form is exceptional. His squat depth is bananas. It's really crazy. I thought he learned that from you. You're saying not.
No, he wanted to train with me, and I was like, I can't lift with you at 6 a.m. I wouldn't be able to make it through the rest of the day. I can't do death metal and banging my head on a bar and then try to see people. I'm just not built like that.
He is such a lunatic. Okay, shout out to Brett. Who's the best strength coach you've ever seen?
Come on.
Outside of the one that you're married to.
Okay, best strength coach outside of Mara.
Could be at a conference. Could be you saw him in Special Forces. Could be
Coach Slats in Special Forces. That's my guy.
Because
I love the guy.
What do you love about him?
He's a teddy bear, man. He's just the man, and he's just I love giving him a hard time. He's just a traditional like football guy. Brian Amenta, I think he's him and Ben Hoffman are very similar. Ben Hoffman's at Maryland. Those are two of the best strength coaches I've been around. They're even keel guys. They know the science, and all their athletes like them. They work with very different teams, but they all like working with these guys because they adapt to the athletes that they see.
I don't know Hoffman, but I know Amenta really well. I'm amazed at the humility. He is there for the athlete, and that is his guiding light. And it's not about how much. It has nothing to do with Brian Amenta. It's everything to do with the athlete. And I think that is the mark of a great strength coach. It's made a mark of a great PT also. That's why I appreciate your social media answer.
Thanks.
Yeah. Okay. Closing words of wisdom to the millions of young PTs that are listening to this pod. Tell them what they need to focus on for the next 5 years.
Are these new grads?
Yeah, new grads. Yeah, new grads and rookies is a high percentage of our listenership.
I think we have this influx, and this is in the strength and conditioning and PT world, of the research readers and want to know the science. All that stuff is very important, and you have to know that. But the soft skills are everything. If you want to differentiate yourself in this field, you have to be likable. You have to be able to connect with people. So build those skills. Be very intentional with how you talk to people and how you interact with people when they're coming in for PT.
Yeah, I mean, the good news is you can practice that all day, every day, every single person you interact. Any books you've read or pods you've listened to or any guidance there as to how to get better at those skills?
So Brett Bartholomew, I don't know if you know that name. He's a strength coach.
Yep.
He writes about this stuff all the time. He's got a book, Conscious Coaching. Not that, like, again, don't just read a book and think you know how to deal with these athletes, but it gives you this framework of here's the different athlete archetypes and how you might interact with each of them. So at least when people come in, you can bucket, okay, here's I'm going to interact with this person. Here's I'm going to interact with this one. I need to give this person more of the rationale of what I do. And you modify how you talk to each person based on their personality and their archetype.
Yeah. That goes back to like my guys who don't talk in the middle of sets, right? Like you start to see these buckets, and how quickly can you identify what bucket the person is, and how quickly can you switch to once you realize, you know what, this person isn't exactly like that. I think that goes a long way. I knew this would be an awesome conversation. I hate that it took so long to get you on here. We got to do it again. I have a feeling you're going to be highly requested to get you on again. What's our topic next time?
I mean, we really only touched the surface of force plays. We could go down there. Okay, we could keep talking about this, coach. Whatever you want to talk about.
I love it. Okay, we'll poll the audience. Guys, thank you so much for listening. Rob, thank you so much for your time. Is there a way for people to get in touch with you?
If you want to go on my Instagram. No, I'm kidding. You can find my email on the School of Medicine website. LinkedIn, I'm on there.
Okay, what's your email?
rrowland@umaryland.edu. So go to the website and find it.
Okay, Rob, thank you so much. Really appreciate you. Guys, thank you so much for listening. Tell us what you love. Tell us what you hated. Tell us who you want to have on next. Thank you so much. Bye-bye.